Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast episode, we're talking with an expert on the pharmacological treatments for obesity. The same expert will join us in a subsequent episode to talk about endobariatrics. Well, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, Australians who are either overweight or obese are increasingly turning to pharmacological approaches coupled with dietary measures to achieve their weight loss goals before considering bariatric surgery. Now, these therapies are typically considered for adults whose BMIs are equal or above 30 kilograms per metre squared or above 27 kilograms per metre squared with associated comorbidities. And the therapies include incretin-based therapies, which also embraces dual incretin agonists, which are the most effective, appetite suppressant central acting drugs, dopaminergic opioid pathway modulation therapies, and finally, nutrient absorption inhibition therapies, which have become less used in Australia and around the world. But the most effective pharmacologic treatments available in clinical use are synthetic incretins. Now, natural incretins are gut-derived hormones which are released after eating, and they enhance pancreatic insulin secretion in a glucose-dependent manner. Well, the so-called incretin effect is where insulin is released from the pancreas by ingestion of oral glucose, more so than by intravenous glucose at the same blood level. And that's now understood as it's mediated predominantly by the release of these hormones. There are two physiologically important incretins, including GLP-1 and GIP. Well, GLP-1 stands for glucose or glucagon-like peptide, which was first discovered 50 years ago. This hormone shares the same ancestry as glucagon, being derived from the same precursor molecule, a proglucagon, but has got completely opposite hormonal effects. So GLP-1 is secreted predominantly by L cells in the distal ileum and colon, with smaller amounts from pancreatic alpha cells in the brainstem. And its release is initially triggered by neural signals while eating, and then in a more sustained way after 30 to 60 minutes by carbohydrates, fats, proteins, and fibre, making contact with the L cells. And GLP-1 is insulinotropic, stimulating the pancreas to release more insulin when blood sugar levels are high. It also increases satiety, slowing gastric emptying by reducing stomach muscle contractions and increasing the tightness of the pyloric sphincter. And this effect is primarily mediated through the vagus nerve and brain centres like the dorsal motor nucleus. But additionally, GLP-1 acts on the hypothalamus in several key areas, primarily the arcuate nucleus and the paraventricular nucleus. And it activates neurons that release anorectic peptides and inhibit those releasing the appetite-stimulating orexigenic peptides. This reduces cravings and regulates hunger. Well, natural GLP-1 has a very short half-life and it's degraded by enzymes, including the very widespread dipeptidyl peptidase 4, the DPP4. And that takes 1 to 2 minutes normally. However, synthetic GLP-1 receptor agonists mimic the GLP-1 hormone and resist rapid breakdown and last for a prolonged period. Now, examples in clinical use of these synthetic GLP-1 receptor agonists include exenatide, marketed as Byetta, which is a synthetic version of a peptide found in the saliva of the Gila monster lizard. Semaglutide, marketed as Ozempic, which is approved for type 2 diabetes, and Wegovy, which is approved for weight loss, with dosing up to 2.4 milligrams on a weekly schedule. Liraglutide, or Saxenda, is daily dosed. And there's another well-known GLP-1 agonist called dulaglutide, marketed as Trulicity. Well, when applied for weight loss, semaglutide and liraglutide lead to 10 to 15% body weight reduction. And for many people living with obesity, this level of weight loss is not just cosmetic, as it reduces the risk of heart disease, joint pain, improves mobility, and boosts quality of life. And benefits beyond diabetes and weight loss include a 30% reduction in the risk of heart attacks and strokes. So these drugs also show promise in treating conditions such as fatty liver disease, obstructive sleep apnea, and kidney disease. But the side effects are there, and these include nausea, vomiting, diarrhea, gallstone production, and pancreatitis in 0.2 to 0.3% of studies. They are contraindicated also in patients with medullary thyroid cancer. Well, the other incretin in clinical practice is gastric inhibitory polypeptide, GIP, which is also known as glucose-dependent insulinotropic polypeptide. And like the GLP-1 incretin, GIP also stimulates insulin release in a glucose-dependent way, although it was first named for its weaker ability to inhibit stomach acid. GIP is primarily produced and secreted by K cells, which are located in the mucosa of the duodenum and jejunum. Its secretion into the bloodstream is also rapidly triggered by the presence and absorption of nutrients, particularly glucose and fats after a meal. The highest concentration of GI-producing K cells is found in the most proximal part of the small intestine, which is consistent with its role as an early response signal to food intake. Now, some studies have also detected minor GIP expression in other tissues, including pancreatic alpha cells, the brain and the stomach. The hormone has no effect on gastric emptying, but, like the GLP-1 agonists, also inhibits satiety through actions mediated in the hypothalamus. The synthetic so-called twincretin or dual-action incretin, called tirzepatide, combines GIP and GLP-1 agonist actions and further increases weight loss outcomes. Marketed as Mounjaro, clinical trials demonstrate it produces 20 to 22% weight loss for patients. Large trials also show that Mounjaro significantly reduces the risk of major cardiovascular events and all-cause mortality. Well, discontinuation rates for patients using incretin therapies for weight loss is quoted between 50 to 75% in 1 year. It's quite high, with factors including expense and side effects influencing the statistic. Also, recent data points to significant weight regain over a 2-year period after medication withdrawal, which is disappointing. The second group of drugs, the centrally acting appetite suppressants, include phentermine, which is a sympathomimetic noradrenergic agent used short-term over weeks and months, which increases noradrenaline and dopamine in the hypothalamus. This leads to a reduction in appetite. It's often combined with topiramate for added satiety enhancement, as topiramate affects the GABA-glutamate signaling. Now, these therapies can expect an 8 to 12% weight loss, and adverse effects include tachycardia, hypertension, insomnia, and teratogenic concerns. The third group of drugs include naltrexone, often combined with bupropion. This acts on the POMC neurons, reducing appetite and food cravings. Nausea, seizure activity, and hypertension are side effects for a quoted 5 to 9% weight loss. The last group is the inhibitors of fat absorption, and that's orlistat. It inhibits pancreatic lipase and decreases fat absorption by about 30%. Steatorrhea and loss of fat-soluble vitamins are side effects for only 3 to 5% weight loss. Well, the future may see triple therapy combining GLP-1, GIP and glucagon, and their development is equally weighted. To discuss the application of these therapies in more depth, we're joined by gastroenterologist Dr Matthew Peverelle. Now, Matthew completed his advanced training in gastroenterology at Monash Health and Austin Health, including the Victoria Liver Transplant Unit. He then continued his studies abroad, completing a hepatology fellowship at the prestigious King's College Hospital in London. Subsequently, he's developed a strong interest in both hepatology, luminal gastroenterology, and endobariatrics. Well, thank you for joining us as he brings his expertise to the next 2 podcast episodes. Dr. Matthew Peverelle, welcome to Everyday Medicine. Thank you very much, Matthew. You're making your time available to us tonight, and we appreciate your expertise on this podcast. Matthew, we've had the privilege of working with you through the course of the year, and we welcome you to our gastroenterology service, and you've been a great colleague. But you've got some special interests that I was keen to just explore with you, both in liver disease, and today we're going to be talking more about your interest in sort of the medical management of weight loss. We've had discussions with surgeons before. We really want to get a medical perspective and an endoscopic perspective. So before we launch into that, Matthew, just give us a little bit of your background, your journey into medicine, Matthew. How did you get here? Take us through it.
Yes, absolutely. Thanks for having me on, Luke. I know it's late on a Thursday evening, so I know we're both pretty tired, but we'll make this good. So interest in medicine probably started earlier on in life. My parents are in the healthcare field. And so that kind of piqued my interest, and then didn't quite have the grades getting out of year 12, but kept going at it, and eventually managed to get a spot at University of Melbourne, and then did my internship. And most of my training was done at the Austin Hospital. And I think that's where my particular interest in liver came about, because the Austin is it's where the liver transplant unit is for Victoria and Tasmania. So very liver centric, but obviously gastroenterology is not just the liver, it's other parts of the gastrointestinal system, stomach, bowel, pancreas, etc. And so part of my advanced training, I went overseas to the UK for a bit over 12 months and worked at King's College Hospital there in London, where it's a very renowned liver centre for both transplant and non-transplant medicine. But I do really enjoy endoscopy. And so one of my mentors suggested that I look into endobariatrics, which I hadn't actually, you get next to no training, and most people I don't think really even know it exists.
Yeah, sure.
I certainly didn't in my final year of advanced training. And so, but since coming back from King's College, I've started uptaking this as part of my practice that I offer to patients. And it's a nice intersection for me because it combines my interest in liver medicine and fatty liver disease, and what term is now metabolic dysfunction associated fatty liver disease.
Yes.
It combines my interest in that with a bit of background interest in obesity and obesity medicine and the physiology of obesity. So it's a nice kind of intersection of the Venn diagram, if you will.
It's a very substantial topic now, isn't it? And it's a very major medical problem that everyone is facing, not just its influence on the liver, but also, of course, with type 2 diabetes and cardiac disease. And
especially in the Western world, but even in the Eastern world now. But the combination of a sedentary lifestyle and the Western diet and fatty liver disease is becoming, and soon to be, if not already, the number one leading indication for liver transplantation. So people often think it's just people who have been alcoholics in the past or have had hepatitis C, but it's actually, in fact, people who are quite metabolically unhealthy.
And consequences in relation to the development of hepatocellular carcinoma and, of course, liver failure. So we're seeing that in our clinical practice. So, Matthew, when you approach someone who's got a high BMI, just take us, and we want to break this into two parts, this conversation. The first part will be more about the medical pharmacological approach, and the second part, the very interesting endobariatric approach. But just take us through, what do you think? Someone comes into the room and they've got fatty liver, their BMI is high, maybe they're type 2 diabetic as well, and you start wanting to try and assist them on their weight loss journey. What's your approach to that? Take us through it.
Yeah, sure. I mean, it's fairly common to have this kind of referral from GPs or other specialists to a patient who has, mild to moderately deranged liver enzymes, liver function tests, and they have features of the metabolic syndrome. They have central adiposity, so they're obese or overweight. They have maybe some insulin resistance, if not diabetes, and they can have high blood pressure and high cholesterol. Well, I mean, first, my approach is to characterize what features of the metabolic syndrome they have, because part of the management of one's fatty liver disease is to optimize each of those individual components, whether that's someone's blood sugar control, if they've got diabetes, or, aiming for a blood pressure as close to or below 120 on 80 as one can tolerate. I then assess them for other complications of obesity. Osteoarthritis is very common amongst these people, obstructive sleep apnea. I then characterize what class of obesity they have, so whether it's class 1, which is BMI 30 to 34.9 or above, class 2, class 3. If they've been referred, for example, elevated liver function tests, then part of that will just involve a liver panel, just checking for other things like viral hepatitis, autoimmune liver disease, which I'm sure you're very familiar with. Most of the time, that tends to be negative. And I think it's very important at that stage, you want to also stage the patient's liver disease. So the way I conceptualize it to patients is, you have a scale of 0 to 4. 0 is, a pristine newborn baby's liver. 4 is really quite severe liver damage, so liver cirrhosis. We need to figure out where on that continuum 0 to 4 your liver disease is. And so I lean very heavily on a tool that you're very familiar with, the FibroScan. It's an interesting side point. It was initially developed by the French to be able to tell when cheese was ready to be sold, because it's a non-invasive way of measuring stiffness, and the French are very big on their cheese, and they use that as part of their cheese making.
Oh my dear!
Selling process.
My dear.
We've commandeered it for liver purposes. So FibroScans are extremely important and useful for staging one's liver disease. Let's just say that they've got features of the metabolic syndrome. They're a bit overweight. They've got a bit of fatty liver disease, maybe a bit of chronic kidney disease. Very common.
Not cirrhotic at this stage.
Let's say not cirrhotic. Yeah.
They want to get their weight down. Yeah. How will you approach that?
So Most people have tried some different forms of diet and exercise. It can be quite demoralizing because most of the time the weight will slowly creep back up. And that is because if you measure hormone levels that control their appetite and basal metabolic rate, so ghrelin, neuropeptide Y, leptin, these will be elevated and declined in such a way that the body is primed to regain the weight. And those hormone levels will not return back to their baseline until the weight has been regained. So it's why, people yo-yo diet, for example.
Yeah,
because
it's fascinating. Do we understand, just talking about that, why, given it's an unhealthy BMI we're talking about with these patients, that the set isn't a normal level of hormones that bring us back to a more normal BMI? Like it seems to be, as you say, people talk about survival, some sort of survival mechanism, but you get to a certain weight that might be very, very high. But they keep, as you say, being pulled back to that weight, regardless of the diet. Do we understand why the set points don't readjust to normal?
Look, I think people are born with a set point, and I think through Western diet, being sedentary, overnourishment, they do put the weight on. I think the way I conceptualize and the way I understand is it's our body's evolutionary process. We don't know when, or we didn't know when our next meal was going to be. And so we are primed to, in periods of starvation or reduction in calories, our metabolic rate goes down and we're primed to store energy as fat. That's my understanding.
The high set point is the point that sort of takes preference.
Yeah, exactly right. And so, ideally the key is to not get overweight in the first place, not get overnourished in the first place. But we don't see that, obviously. We see people who have been overweight or obese for many, many years. And so that's something that ideally is targeted in childhood, but, we're not dealing with pediatrics. So we kind of have to deal with what's presented to us.
Do you know the answer to this question? After a period of time, someone might have been very overweight. Over a period of time, they've re-entered a more healthy, normal BMI. Do we know if their ghrelin and the various other hormones we've just mentioned there from the hypothalamus, do they all tend to come back to a lower level and stay there? Or is there, even after 5-10 years, a tendency for those levels to be pulled back up again? Do we know that?
Look, my understanding is that they do eventually go back to
reset properly.
Reset, but it takes a long time. So it's very hard for people to maintain the weight loss whilst fighting that hormonal change. But no, my understanding is that they do slowly over time, and I'm talking beyond 12 months, return to kind of the pre-morbid baseline.
Yep. Okay. So we've thought about exercise and we've thought about like diets, which are lower in calorie and so forth. What is your pharmacological approach? Where do you go to? We've got older drugs and newer drugs. Just take us through perhaps the older drug panel and whether you use any of those, and then the newer drugs that are available.
So the older drugs, the two that I'm mostly familiar with, one is Orlistat, which is a lipase inhibitor. It's been around for quite a while. I'm not sure how much experience you have using it. That can produce a couple of kilos of weight loss over a 12 to 24 month period. But as you're aware, by inhibiting fat absorption, people do get quite a lot of gastrointestinal side effects, nausea, bloating, flatulence, altered bowel habits. So I'm not even sure if that one requires a prescription, to be honest. I think that one can be purchased without one. Have you got much experience using this one recently?
I have never actually prescribed or been involved with it because it doesn't stop sugar absorption. So when it first became available some time ago, patients were certainly complaining about the side effects of the drug. And it's never been hugely successful, but maybe it's something one would use as an adjunct to other treatment. And I'm going to
There is I don't think it's certainly not going to form the backbone of your obesity management. It may be an adjunct, as you said. Yeah. Then you have Fentop, it's a combination of phentermine, which has noradrenaline, dopamine releasing effects. And then it's also combined with topiramate, which is usually, as you're aware, used as an anti-epileptic, but can have some off-label appetite suppressant effects. That is approved for weight loss and can achieve around 10% loss of weight after 12 months or so. But people do run into side effects, and particularly with the phentermine component and the sympathomimetic side effects can be a bit limiting. And so, obviously the drugs that have really taken the world by storm are the glucagon-like peptide agonists, GLP-1 agonists, and the family of the other medications that are GLP-1 agonists, but with another agonist such as the GIP, tirzepatide.
Sort of the incretin. So would we say, Matthew, just before we leave those old drugs, they're pretty much off the table now? We're not going to use them very much. Would you ever consider using topiramate, which it's not actually for this indication,
Yeah.
or metformin, for example. Would you ever use these
Yeah.
drugs? And often metformin's here because the patient's diabetic, but
Yeah.
are they drugs that you largely now just sort of consider and think, well, we've got such better drugs with these GLP-1 and GLPs that we're not going to really trouble patients with?
I think there's going to be always a subset of patients who you would consider using these in. There are not an unsubstantial amount of patients who can't use the GLP-1 agonists for they've got a history of pancreatitis
and they're expensive.
And they're obscenely expensive at this stage, and then they're very unlikely to be subsidised because it bankrupt the healthcare system to subsidise them. So no, there are select numbers of patients who
may consider
who you could use. And metformin, as you said, metformin I wouldn't really use necessarily for its weight loss effects per se, but it's quite useful in pre-diabetics and diabetics.
I just checked. You can buy orlistat, but in small numbers without a script. Yeah, it can be an authority for a larger number, but small numbers. Yeah, you can buy just over the counter. Okay, so that's the older panel of drugs. Tell us a little bit about these incretins, the newer drugs. Take us through your thoughts here. What we should use, how we should use them, and so forth.
Yeah, of course. The history of them is quite interesting. I remember going through medical school, and the first GLP-1 that I heard about was exenatide, or the trade name was Byetta, and it was initially created as a diabetes medication, and they isolated it from the saliva of the Gila monster, which is I think it's a reptile in America.
Right.
And so there have been iterations of exenatide since then, and most famous probably is Ozempic, semaglutide. It's a once weekly injection, and then the weight loss version of Ozempic is Wegovy. So these medications, so semaglutide, as I mentioned before, is a glucagon-like peptide 1 agonist. It mimics the GLP-1 hormone in the body, and thus by doing so, it has a number of different physiological effects that both improve glycemic control, improve blood sugar, and also help people to lose weight. So it increases insulin secretion by the pancreas, and that's partly how it brings people's blood sugar down. It delays gastric emptying quite a lot. People feel fuller for longer. They have reduced stomach capacity as a result of the delayed gastric emptying as well, and that's how they lose substantial amounts of weight. In the realm of 15 to 20% after 12 months. Tirzepatide, which is a newer iteration, and it's a dual agonist, so it's GLP-1 and GIP, which is gastric inhibitory peptide. That produces even more substantial body weight loss after use, in the realm of 20 to 25% body weight loss, actually. These medications are quite obscenely expensive to people who don't often have a lot of money. So they are limited in their availability, and the cost is often prohibitive. But they are extremely effective medication at helping people to lose weight. And then with the weight loss comes the metabolic benefits, reduction in blood pressure, sugars, dyslipidemia. And that usually occurs once you get to about 10% or more body weight loss. And so these medications are extremely effective at achieving that.
There are issues with these drugs over a period of 12 months. A large proportion of patients, I think it's over 40%, don't continue. It may be prices partly, the economic reasons, but it's also side effects. What are the main side effects that we're going to look for when we're prescribing these drugs, Matthew?
Yep, good question. So most patients will get some gastrointestinal side effects. So those can be anywhere from nausea to vomiting to bloating to diarrhea to constipation to abdominal pain. And it's pretty hard to predict who's going to get what side effect. Those side effects are minimized, or they're managed by starting at the lowest dose and going slow up titration once a month.
Yes.
And in doing so, allowing patients' bodies to kind of get used to those side effects. But there are, as you said, a significant proportion of people who are intolerant or are not taking the medication at the 1 year mark, about 40%. And so it's a big unmet need. Those people who have been on a GLP-1 agonist, but at the 12-month mark are no longer taking it yet, they're left with, they might be a little bit lighter than when they started, but the natural history of obesity is that they will put that weight back on gradually over time. And so there's definitely a huge unmet need for particularly those kinds of patients who are either intolerant or cost is prohibitive.
Matthew, what about someone who's had a history of pancreatitis? It might have been gallstone pancreatitis, for example, rather than idiopathic. So we understand the reason for it. Gallbladder's been removed. Problem resolved. Are we concerned about using these drugs in this group of patients? So who do you feel we have to be particularly worried about before we start selecting these incretins? Take us through your thoughts there.
Yeah, I think it's a bit of a tricky one, and I don't think we have a whole lot of data to guide us, to be honest. The incidence of pancreatitis with these medications is low, because the incidence is low, we don't have a whole lot of data to kind of support practices. In the case of someone who's had gallstone pancreatitis and has had their gallbladder taken out, I think it would probably depend, in my eyes, and this is just based on kind of more gut feeling than anything, which is not that valuable, but we don't have a whole lot to guide us. I think if it was a mild case of pancreatitis and their gallbladder's been taken out, then you could make a case to very gently, very carefully commence someone on tirzepatide or semaglutide, provided the benefits that you feel they're going to get out of it outweigh the risk of pancreatitis. I'd be watching those people like a hawk, though.
Not an absolute contraindication. There's also some cardiac benefits that have come to light. We're not sure whether tirzepatide necessarily will be part of this, will demonstrate this benefit. Probably it will. But can you just speak to us a little bit about that with the improvement of major adverse cardiac events? Because we're seeing that in the studies as well, which is something worth noting.
Yeah, definitely. So there have been some pretty large trials published recently in some pretty high impact factor journals, people who have been on one of these GLP-1 agonists or dual agonists over a longer period of time, as you said, whether they've got a history of diabetes or overweight/obesity, have a reduction in MACE, so major adverse cardiovascular events, over a period of time. And I think also, was there a paper about heart failure as well, I think, maybe with these medications, which it improves heart failure outcomes as well. So is this an effect of the medication in some of its physiology actually affecting the heart, or is this just a consequence of people losing weight and getting better control of their cardiometabolic risk factors? I actually don't know the answer to that question.
Hard to know. So let's just have a look at a patient. We've got a patient who you've assessed, you've had a good chat with them about their liver disease, you've staged it, you're concerned about fatty liver, you've gone through the fibro scan, you've got that, and now you're working hard on their weight, trying to get their BMI down. You've discussed the diet with them, you've discussed a potential exercise program, maybe hook them up with an exercise physiologist that might help with their exercise. Then you've chosen perhaps one of these incretin drugs. You're a year down the track, they have lost maybe 10 to 15% of their body weight, maybe more, but let's say 10 to 15% of their body weight. What do you do there? Are you going to keep the incretin going? Let's say they can afford it.
Yeah.
Would you just keep it going, and for how long? What's your longer term?
Look, in my eyes, if I don't have a good reason to stop it and they're tolerating it and cost is not prohibitive, then I would just be continuing it. I would be ensuring, though, that checking, fat-soluble vitamins. I'm making sure that they're eating adequate amounts of protein in particular, because one of the concerns with these medications is a lot of the weight that people will lose will be muscle mass, and so people will be at high risk of falls, high risk of fractures. And so I hammer into all my patients that I want them to be doing some form of resistance exercise, at least once, twice. Yes. Yeah, exactly right. And focusing on protein in their diet. So, but if I don't have a good reason to stop the incretin mimetic, then I'll continue it.
Can you taper the dose? Do you know of any studies which have looked at giving it fortnightly to save the expense? Here they are. They've reached a reasonable target weight loss. You're pretty happy. Now we're going to go to fortnightly. Frequently tapering the dose back just to save, maybe weekly, but a smaller dose to sort of save the expense. Do we know much about that? Hopefully they're getting their ghrelin levels reset, whatever.
Yeah, I'm not sure actually about tricks to kind of extend the lifespan of the pen to, make it a bit more affordable. Just by first principles, I think if you were to down titrate the dose, I suspect that you might see a little bit of weight coming back on, or they might notice that their hunger is a bit more intense than previously, but it would be anecdotal.
Right. To that effect, let's suppose we're at a point where maybe the economics are such that the patient doesn't really want to continue. Would you go back to some of the original drugs, thinking about phentermine or duramine or orlistat? Would you then throw those drugs back in the mix and use them as a second line to try and help manage and maintain the weight? Is that something you would consider doing? No,
that's a good question. Yes, if the phentermine to pyramate combination, it's not that cheap in of itself. It's certainly cheaper than Ozempic and Mounjaro and Wegovy, etc. But I can't remember off the top of my head. It might be something like $90 a month or something like that. So it's cheaper, but it is still, a bit of an out-of-pocket cost. So, but yes, I'd certainly look to lean on those other medications to maintain that weight loss. And I think if the longer you can keep the weight off, that you've bought that person time free of their diabetes or their hypertension or their dyslipidemia. And so you're probably going to translate into longer years of healthy life.
And you're introducing some lifestyle changes during that time.
Yeah, of course.
Do you know anything about, we've got dual action incretins, that's the Mounjaro, tirzepatide. There's triple action medications that are coming in. I think you're in trial at the moment. We're probably going to see these other drugs coming on the market that are, well, we'll wait and see what their results are. But do you know anything about those trials and where the future is in pharmacology? Have you got any thoughts on that?
I mean, it feels like every 6 months they've added on another agonist and they're just finding other receptors in the body to target to cause more weight loss. Retatrutide is the triple agonist I think that you're alluding to.
Yes.
Yep. I think that's so it's the dual agonist plus amylin, I believe, is the other receptor that it targets. And it has shown greater weight loss than tirzepatide, or Mounjaro is the other word for tirzepatide, around 30% body weight loss. So, I mean, it almost seems like the sky's the limit with how much we can get people to lose weight by targeting certain receptors involved in digestion.
I wonder, we're going to talk about endobariatrics in a moment, but I do wonder if these drugs, and as we see other iterations of these incretins, whether we're going to see a lot of bariatric surgery perhaps reduce in frequency and volume. Is that a prediction that you might consider? Because if these drugs are working well, what's your thought there?
No, certainly. I think anecdotally speaking, from knowing of some surgeons that operate elsewhere, that there certainly has been a decline in the number of people seeking out bariatric surgery. I guess it's going to be interesting to see what happens in a few years down the track when people, may get sick of injecting themselves, or cost may be prohibitive, or they have some side effects or an adverse effect from the medication. That means they can no longer take it, but they desperately want to keep their weight off. I wonder if there'll be some patients who would never have thought of endobariatrics or bariatric surgery who will then seek out a gastroenterologist or a surgeon to discuss those procedures. I think time will tell. Well,
Matthew, thank you very much for taking us through the medical side of the way a gastroenterologist thinks about weight loss. We're going to take a little pause and we're going to invite you back and we're going to talk about endobariatrics.
Great. Thank you, Luke.
I'd like to thank you for joining me with Matthew Peverelle, where we've discussed the pharmacological therapies now in use for obesity. I certainly hope you've enjoyed this. Please join us again also in the next episode where Matthew will be discussing endobariatrics. Well, during the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au.